Namaste. This session we will be seeing about obstructive lung diseases, the pathophysiology of obstructive lung diseases. So, I will be dealing with this topic in these objectives: introduction, risk factors, pathogenesis, pathology, and finally summary. So, the introduction. Obstructive lung diseases are mostly chronic. There are only acute exacerbations. So, chronic obstructive lung diseases are characterized by an increase in resistance to airflow due to diffuse airway disease, which may affect any level of the respiratory tract. And what is chronic obstructive pulmonary diseases? These are different and they comprise of chronic bronchitis and emphysema. So, COPD, that is chronic obstructive pulmonary disease, chronic bronchitis and emphysema with bronchial asthma and bronchiectasis constitute the entire spectrum of chronic obstructive lung diseases, which are called cold. So, with regard to pulmonary function test, this code shows decreased maximal airflow rates during forced expiration, usually expressed as forced expiratory volume at 1 second, which is called FEV1, over forced ventilatory capacity, that is called FVC. So, an FEV1 FVC ratio of less than 0.7 generally indicates obstructive diseases. The expiratory airflow obstruction may be caused by a variety of conditions, each with characteristic pathologic changes and different mechanisms of airflow obstruction. However, these divisions between the entities are not clean, and many patients have diseases with overlapping features like how we see here. So, chronic bronchitis and emphysema are generally small airway diseases due to chronic injury. In chronic bronchitis, it is chronic cough with airway obstruction. In emphysema, it is alveolar wall destruction with overinflation. A subset of these patients can also have bronchial asthma, which is reversible obstruction due to bronchial hyperresponsiveness triggered by allergen, infections and pollutants. So, you see that there is a central watershed area which comprises of patients with all three overlapping features, and those are the patients who are called as chronic obstructive pulmonary diseases. Moving on to the etiology of the chronic obstructive pulmonary diseases, 85% of these obstructive pulmonary disease patients are smokers. 15% of them are non-smoker, where in developing countries especially, non-smoking COPD is 30 to 50% due to what is called biomass fuel, where wood, cow dung and crop residues are burnt, and these lead to release of air pollutants like sulfur dioxide, carbon monoxide, nitric oxide and formaldehyde, and particulate matter smaller than 10 micron in size, which is PM10, in the ambient indoor and outdoor air. There are also occupational smoke and dust, which are important causes for COPDs. Tuberculosis in India especially has 2 to 6 times increased lifetime risk for COPD. Recurrent respiratory infections in childhood is thought to be an increased risk factor. Poorly treated bronchial asthma also leads to chronic obstructive pulmonary diseases. Aging is one of the important factor, and amongst the genetics, it is very important because there is what is called deficiency of alpha-1 antitrypsin, which is in the gene SERPINA coding, and that deficiency generally leads to emphysema. Coming to risk factors, it can be classified as modifiable risk factors and non-modifiable risk factors. Coming to modifiable risk factors, we see that cigarette smoking is one major risk factor, followed by occupational environmental exposures, socioeconomic status, dietary factors, tuberculosis, intravenous drug abuse and immunodeficiency status. Coming to non-modifiable, of course, genetics is the major, and gender, developmental factors like presence of small lungs at birth, and vasculitic and connective tissue disorders, which are also genetic in nature. Coming to various hypotheses with regards to pathophysiology of chronic obstructive lung diseases, Reed in 1960 highlighted the increased mucus gland size in his pathologic studies and developed the Reed index and highlighted the anatomic basis for chronic bronchitis. And there was Dutch hypothesis where bronchial asthma and airway hyperreactivity was thought to lead to the fixed airflow limitation. And British hypothesis where mucus hyperis secretion is thought to be the major factor which leads to airway remodeling and airflow limitation. And then comes the protease and antiprotease hypothesis, which is very important, which is from the Swedish hypothesis where association of homozygous alpha-1 protease inhibitor deficiency is associated with emphysema. And American hypothesis is the latest, which says that American pathologist Avril Lebo emphasized that altered repair mechanisms contribute to the development of chronic obstructive pulmonary diseases, and that deficient maintenance of lung structure could lead to emphysema. Coming to the pathogenetic factors, there are 4 important pathogenetic factors which play an important role in development of chronic obstructive pulmonary diseases or lung diseases. The first and the foremost is inflammation, persistent inflammation. Second is of course the balance between the proteinase and antiproteinase, or what are called protease and antiprotease imbalance. And we have oxidative stress and apoptosis, that is programmed cell death. All these 4 factors play an important role in the pathogenesis or development of chronic obstructive lung diseases. Coming to inflammation and COPD. So, the inflammatory cells which participate in chronic obstructive pulmonary diseases or COLD are macrophages mainly, neutrophils more important, natural killer cells and T lymphocytes linked through dendritic cells. Increased release of oxidants and proteases, perpetuating the imbalance in favor of lung destruction. This is what these inflammatory cells do, and especially the neutrophil elastase increases the macrophage and epithelial cell activation as well, and represent a major stimulus for mucus production and secretion by goblet cells, which are the lining cells of the bronchial epithelium, and the mucus glands which are present underneath, and this is supposed to be the hallmark of chronic obstructive pulmonary disease, that is secretion of mucus and increased production of mucus. So, the chemical mediators from all these cells also play a very important role in chronic obstructive pulmonary diseases. So, what are these chemical mediators? Especially interleukin 8, which is a chemotactic factor for neutrophil, and then we have these chemokine ligands. These are the CXC chemokine ligand 1 and 8, and also the presence of increased CC chemokine ligands CCL2, 4, 17 and 22, along with CXC chemokine receptor CXCR2. These play a very major role in the inflammation of the COPD. Also, there are certain oxidants which are released from these inflammatory cells, which are also responsible for the destruction and airway. One is hydrogen peroxide and second is superoxide anion. And as I already said, the balance between proteases and antiproteases. So, if there is an increased proteases because of these inflammatory cells, that is the matrix metalloproteinases and the tissue metalloproteinases, which is MMP9, and some of the growth factors as well are responsible. And lastly, in bronchial asthma, it is leukotriene B4 and tumor necrosis factor alpha, which are also responsible for airway obstruction. Coming to the protease antiprotease theory and alpha-1 antitrypsin deficiency, these two are related together. The balance between matrix degrading proteases and their endogenous inhibitors, that is antiproteases, determines whether the lung is protected or susceptible to proteolytic injury. So, these proteases come from neutrophil, which is the neutrophil elastases, and the matrix metalloproteinases. These are released from inflammatory cells, especially neutrophil, and also the epithelial cells that break down connective tissue components. And alpha-1 antitrypsin, this is normally present in serum, tissue fluid and macrophages. It is considered to be the major inhibitor of the proteases which are coming from the inflammatory cells and the epithelial cells, especially neutrophil elastase. And this alpha-1 antitrypsin is encoded by proteinase inhibitor locus PI on the chromosome 14. So, there is a genotype associated with very low serum levels of alpha-1 antitrypsin in the Z allele, and 80% of these ZZ homozygous individuals develop what are called symptomatic pan-acinar emphysema, occurring at an earlier age and is of greater severity if the individual also smokes, which increases the protease level and which can't be dealt with alpha-1 antitrypsin due to their deficiency. So, it is postulated that any injury, example that induced by smoking, which increases the activation and influx of neutrophils into the lung, will lead to local release of proteases, which in the absence of alpha-1 antitrypsin, which is an antiprotease activity, result in excessive digestion of the elastic tissue of the lung and with time leads to emphysema. So, it forms one of the major pathogenetic mechanisms. Oxidative stress and apoptosis. Substances in tobacco smoke and along with alveolar damage and the presence of inflammatory cells, all these produce oxidants which may beget tissue damage, endothelial dysfunction and inflammation. The NRF2 is a transcription factor that serves as a sensor for oxidants in many cell types including alveolar epithelial cells. Also, intracellular oxidants activate this NRF2 which upregulates the expression of genes that protect cells from oxidant damage. There are genetic variants in NRF2, NRF2 regulators and NRF2 target genes which are all associated with smoking related oxidative damage leading to lung disease in humans, especially obstructive lung diseases. So, cell death by injury or apoptosis can be an initiating trigger for emphysema, and this was proved by experimental models showing that non-inflammatory cell death can initiate airspace enlargement, inhibition of vascular endothelial growth factor receptor being the major responsible factor, or sometimes installation of active caspase 3 which is considered to be an apoptotic factor in lung epithelial cell tissue leading to apoptosis and damage to the alveolar wall leading to what is called emphysema. So, actually coming to what happens. So, at one end of the spectrum is genetic susceptibility where there is long-term deficiency of alpha-1 antitrypsin, and the other side is the environmental insults to lung which are sometimes inevitable but also associated with smoking, pollution in the air and certain infections. So, all these together, the genetic susceptibility leads to decreased lungs' ability to prevent damage to lung parenchyma, whereas environmental insults to lung will lead to increased production of free radicals in the lung and also inactivation of the lung antiproteases because of infection and smoking, which leads to accumulation of neutrophil which releases the proteases actual. And these three together, that is decreased lungs ability and free radical inactivation of lung antiproteases, will lead to lung inflammation where there is increased oxidative stress, inflammatory cytokines and protease function. So, these three factors together will either lead to continued repeated injury to bronchial tree or may lead to increased proteolytic destruction of the lung parenchyma. Depending on which side is the balance, if it is continued repeated injury to bronchial tree, the patient may have these things, that is infiltration by neutrophils, goblet cell proliferation leading to mucus secretion, death of airway ciliated epithelial cells. These three factors will lead to bronchial fibrosis and lumen narrowing, and the trapped mucus in the airway will serve as a source for further infection leading to more neutrophils, and together bronchial fibrosis, lumen narrowing and trapped mucus is what is called leads to chronic bronchitis. So, these are called the blue bloaters. Whereas, if the balance is that there is increased proteolytic destruction of lung parenchyma leading to decreased airway elasticity, that is less recoiling of the lungs and decreased structural support of airway patency and permanent damage to airway epithelium. So, if these three happens, then there is trapping of air within the lung because of decreased elasticity, and there is airway narrowing and collapse because of decreased structural support of the airways, and due to permanent damage of the airway epithelium, lung goes in for hyperinflation and there is bullae formation because of the ruptured air sacs. So, when there is hyperinflation and bulla formation and there is trapping of air within the lung, there is what is called emphysema, where the lung is overinflated with more air within it and appears very darker in color, and this is called emphysema. So, depending on which is more, if the bronchial tree injury is more, the patient will become chronic bronchitic patient. If there is increased proteolytic destruction of lung parenchyma, leads to emphysema. These are pink puffers. Now, cigarette smoking and inflammation, a very important pathogenetic mechanism, because smoking is one of the major cause for chronic bronchitis or emphysema. So, smoking leads to persistent stimulus for inflammation. How? One is by activating epithelial cells. Second is senescence of fibroblasts, where the fibroblasts undergo degradation. So, this activation of epithelial cells leads to increased growth factors, that is mainly the platelet derived growth factor and the TGF beta. So, this transformation growth factor beta is responsible for fibrosis as well, and The senescence of fibroblasts leads to increased matrix metalloproteinases. So, there is also activation of macrophages and lymphocytes when there is smoking, increased persistence of the stimuli, and that leads to increased cytokines and chemokines, which we already saw, the ones being interleukins, mainly interleukin 13, tumor necrosis factor alpha, and the monocyte chemotactic factor 1, protein 1. All these three lead to one side matrix synthesis, the other side matrix degradation because of matrix metalloproteinases. So, this matrix synthesis with matrix degradation leads to what is called a scar or lung fibrosis. So, when the lung undergo fibrosis, obviously the patient airway is obstructed and there is what is called collapse as well. So, coming to the morphology of chronic bronchitis, that is pathology. In chronic bronchitis, there is thickening of the bronchial wall by mucus gland, enlargement and edema resulting in encroachment on bronchial lumen. This is very important. There is increased mucus gland, enlargement and edema resulting in encroachment on bronchial lumen. So, there is narrowing of the lumen. Excess mucus because of the increased mucus gland in the central and the peripheral airways is another important pathology. An increase in the number of goblet cell, what is called goblet cell hyperplasia in the bronchial epithelium is seen in all these cases, and increased smooth muscle which may indicate bronchial hyperreactivity is also present. And because of all these changes, there can be metaplastic change of the bronchial epithelium leading to squamous metaplasia of the bronchial epithelium, reflecting the epithelial damage from tobacco smoke, which is probably independent of other changes in chronic bronchitis. So, these are the major pathologic changes we see in chronic bronchitis. Here it is seen that what is Reed index. This Reed index determines whether patient has got a severe or mild bronchitis. So, Reed index is actually what is called A, that is thickness of the mucus layer in the mucosa, and the ratio of the thickness of the entire wall thickness of the epithelial lining, that is from the epithelial lining to the cartilage. So, this layer length of the mucus gland or depth of the mucus gland along with the entire length of the mucosa. So, the ratio between them determines the Reed index. And in case of chronic bronchitis, this is what actually happens. This is a normal lumen where it is patent, airway patency is maintained. But when there is chronic bronchitis, because of smoking and epithelial damage and inflammation and mucus secretion, the lumen is narrowed and there is what is called a very small pinhole, and this leads to chronic bronchitis. Coming to morphology of emphysema. There is irreversible enlargement of air spaces distal to the terminal bronchiole accompanied by destruction of their walls. That is what is the major change in emphysema. That is irreversible enlargement of the air spaces which is in the terminal bronchiole or beyond the terminal bronchiole accompanied by destruction. Here you can see that these are the normal acinus, where these are the respiratory bronchiole and these are the alveolar duct and the alveolus. In case of centriacinar emphysema, what is called a central enlargement, there is enlargement of these respiratory bronchioles or what is called irreversible enlargement without much inflammation, and the terminal part is normal. Whereas in case of pan emphysema, that is emphysema affecting the entire acini, then you have the what is called the respiratory bronchiole along with the alveolar duct is also enlarged, and that is what is called pan-acinar emphysema. So, major morphological types are the centriacinar, the centrilobular, what we saw here, which is commonly seen in smokers, whereas the second major type is the pan-acinar or the panlobular emphysema, which is associated with alpha-1 antitrypsin deficiency. And we also have distal acina, which is called the paraseptal emphysema, and we have the airspace enlargement with fibrosis, which leads to irregular emphysema. So, this is how a lung will appear when it is emphysematous, where there is overinflation with increased air trapped, and also at grossly you will see that the lung becomes almost like a tubule, and you can see these increased dark pigment, these are the anthracotic pigments. And here you see in the microscopy, these are the alveoli, which this is the normal alveoli, you see this is the normal side, and here you see that this is emphysematous, where you see dilated air spaces with minimal inflammation in the interstitium. So, diagrammatically, pan-acinar is where the entire alveoli, alveolar duct and the acini are all enlarged, whereas centroacinar is where only the respiratory bronchiole is enlarged, whereas the peripheral part, that is the alveolar duct and the alveolar acini, are maintained. Now, coming to the other aspects of chronic obstructive lung diseases, that is bronchial asthma, most important, the etiopathogenesis and types. Asthma, as we all know, is a heterogeneous disease where there is chronic airway inflammation and variable expiratory airflow obstruction leading to wheezing, shortness of breath, chest tightness and cough. There are 4 major types. One is called the atopic IgE mediated allergen induced bronchial asthma. Second is non-atopic, where infections, environmental fumes and pollution are the causative agents in non-atopic. And there is also drug-induced bronchial asthma, where most of the patients have history of taking aspirin sensitive asthma, inhibiting the cyclooxygenase pathway of the arachidonic acid metabolism, leading to a rapid decrease in prostaglandin E2. And occupational asthma is where the fumes, the organic and the chemical dust, gases and chemicals like formaldehyde will lead to due to the occupational exposure. Once they are taken out of the occupational exposure, these patients do not have any kind of symptoms. So, coming to the pathogenesis, as we know, bronchial asthma is characterized by reversible bronchial obstruction or what is called bronchoconstriction caused by airway hyperresponsiveness to a variety of stimuli. So, in atopic asthma, it is mainly caused by what is called a Th2 response and an IgE mediated immunological reaction to the environmental allergens and is characterized by acute phase, that is immediate and late phase reaction. The Th2 cytokines are mainly the interleukin 4, interleukin 5 and interleukin 13. These are the 3 major important mediators for Th2 cytokine leading to atopic asthma. And out of these, eosinophils are the key inflammatory cells in atopic asthma. Other inflammatory cells implicated in its pathogenesis include the mast cell, which is the equivalent of basophil, the neutrophils and the T lymphocytes. Now, triggers for non-atopic asthma are less clear, but majorly include the viral infections and the inhaled air pollutants, which can also trigger atopic asthma sometimes, leading to IgE production and eosinophils. Genetics in asthma, this is very important. This is a very recently upcoming field where we have seen that more than 100 genes are implicated, and the most important being a gene in chromosome 5q and ADAM33, and these mutations can lead to development of bronchial asthma. And airway remodeling is considered to be the latest theory, where there is a subbasement membrane fibrosis, hypertrophy of the bronchial gland and smooth muscle hyperplasia will add on to the irreversible component to the obstructive diseases. So, these form the major pathogenesis of bronchial asthma. Coming to Th2 cells, this is very important because most of the bronchial asthma cases are atopic cases, and this Th2 cell releases cytokines which are interleukin 4, 5 and 13, which these interleukins promote allergic inflammation and stimulate the B cells to produce what type of antibody? Mainly IgE antibodies. So, interleukin 4 is responsible for production of IgE from the stimulated B cells, whereas interleukin 5 activates the recruited eosinophils which has come because of IgE, and interleukin 13 is responsible for mucus secretion from the bronchial submucosal glands. So, all 3 together are responsible for the changes seen in bronchial asthma. So, what do we see in early phase? That is immediate hypersensitivity reaction. Here the patients will have bronchoconstriction, increased mucus production, vasodilatation and increased vascular permeability. Whereas in the late phase reaction, the inflammation is more severe with recruitment of mainly eosinophils, neutrophils, T lymphocytes and also more and more T cells, leading to more and more obstruction and airway hyperresponsiveness. There are three major types of mediators which are implicated. And why have we divided into three major classes? Because of the drugs acting on it. So, putative mediators are the ones which produce bronchospasm. This is the major important clinical factor in bronchial asthma patient seeking treatment. So, bronchospasm could be acute or chronic. If it is acute, patient generally comes with what are called acute exacerbation of status asthmaticus. So, the putative mediators for bronchospasm are leukotriene C4, D4 and E4. So, there are drugs targeting these chemical mediators or what are called leukotrienes. These are extremely potent mediators that cause prolonged bronchoconstriction as well as increase vascular permeability and increase mucus secretion. Then the other important putative mediator is acetylcholine, which is released from the intrapulmonary motor nerves, which can cause airway smooth muscle constriction by directly stimulating the muscarinic receptor. So, these are non-mediator or what are called neurogenic constriction. Then we have the second group of mediators which are called the potent asthma-like effect. So, these mediators produce something like potent asthma-like effect and also acute allergic asthmatic reaction. The major of this is the histamine. Histamine is a potent bronchoconstrictor which is secreted by mast cell and basophil. Prostaglandin D2, which comes from the arachidonic acid pathway, elicits bronchoconstriction and vasodilatation. And the third major factor is platelet activating factor, which causes aggregation of platelets and release of histamine and serotonin from their granules as well. So, again there is increased histamine production, which is a potent bronchoconstrictor. So, these are the second type of mediators which produce potent asthma-like or acute allergic asthmatic reaction. Then we have a third group of mediators which form the larger group of mediator comprising some of the cytokines, that is interleukin 1, tumor necrosis factor alpha and interleukin 6, and also comes the chemokines, of which eotaxin is very important, and we have the neuropeptides, the nitric oxide, the bradykinin and the endothelins. All these are major group of mediators which can also be targeted by drugs. Now, coming to pathophysiology, in a simple way to make it more clear, we have a trigger factor which could be an atopy, which could be an allergen, which could be drug induced or which could be genetically induced, and this trigger factor leads to airway inflammation. This airway inflammation on one side leads to increased mucus hypersecretion because of increased bronchial hyperresponsiveness, and also same time there is increased bronchial membrane swelling, and at the same time the smooth muscle also undergoes constriction. So, all these three things together produces airway obstruction, which leads to wheezing for the patient, persistent cough, shortness of breath and tightness in chest. So, to reiterate that chemical mediators are very important and inflammatory cells are important in the production of this airway obstruction, that is wheezing, cough, shortness of breath and tightness in chest. We have enumerated these cells and mediators along with their effects. So, these are the important cells, mainly the eosinophil, mast cell, Th2 lymphocyte, basophil platelet, and along with the epithelial cells, endothelial cells, smooth muscle cell and fibroblasts. And amongst the mediators, as I already told you, histamine and platelet activating factor, prostaglandins, leukotrienes, kinins, nitric oxide, growth factor, cytokine, chemokine, and these are the major effects, that is the bronchospasm, mucus secretion, plasma exudation and structural changes. So, these form the important cells and mediators of inflammation in bronchial asthma. So, pathology of bronchial asthma, the first point to remember is occlusion of bronchi and bronchioles by thick tenacious mucus plugs. These are the mucus plugs which contain whorls of shed epithelium and what is called the well-known spiral shaped mucus plug in the sputum when we do a sputum examination called Kirschmann spirals. So, collections of these crystalloid made up of an eosinophil lysophospholipase binding protein called galectin-10 produces what are called the Charcot-Leyden crystals, which are also seen in the sputum. So, two important things to be seen in sputum examination: Kirschmann spiral, the Charcot-Leyden crystal. Coming to airway remodeling, there you may see that there is an overall thickening of the airway wall where there is subbasement fibrosis, increase in both type 1 and type 3 collagen. There is also increased vascularity and increase in the submucosal glands of the airway epithelial cells, and there is hypertrophy and the hyperplasia of the bronchial wall muscle. Here you can see there are a lot of inflammatory cells, hypertrophy of the muscle, inflammation, increase in goblet cell, and there is hypertrophy of the muscle. All these lead to what are called airway remodeling. Now coming to the last of the chronic obstructive lung diseases, bronchiectasis. Bronchiectasis, as the name suggests, it is a disease characterized by dilatation, permanent dilatation or ectasia of the bronchi and the bronchioles caused by destruction of the muscle, that is the bronchial muscle, and the elastic tissue resulting from or associated with chronic necrotizing infection. So, two important parameters need to be addressed in bronchiectasis. One is there should be a presence of infection and there should be a presence of obstruction. Only when these two are present, you will get bronchiectasis. Coming to the types, there are congenital or hereditary type, which is cystic fibrosis, intralobular sequestration of the lung, immunodeficiency states, and primary ciliary dyskinesia and cartagenous syndrome. So, these are the most important congenital hereditary conditions, out of which cystic fibrosis, cartagenous syndrome, primary ciliary dyskinesia are all important and should be diagnosed at a very early age. Coming to the second important type of the bronchiectasis is post-infectious or necrotizing pneumonia. So, this is very important because when a patient has pneumonia, the consequence of the pneumonia could be bronchiectasis. So, especially when it is due to Mycobacterium tuberculosis, Staphylococcus aureus, Haemophilus influenzae and Pseudomonas. And some of the viruses, namely the adenovirus, the influenza virus, the human immunodeficiency virus and the fungi, that is the Aspergillus species, all these are supposed to produce what are called post-infectious necrotizing pneumonia leading to bronchiectasis. Sometimes there can be bronchial obstruction because of tumor, foreign body and mucus impaction leading to infection and bronchiectasis. There are also other conditions which are responsible for leading, which can lead to bronchiectasis in patients with rheumatoid arthritis, systemic lupus erythematosus. These are what are called autoimmune diseases where patient can end up with bronchiectasis because of infection and because of obstruction. Also inflammatory bowel diseases post-transplantation, that is chronic lung rejection, and chronic GVHD, that is graft versus host disease after bone marrow transplantation. So, one must remember that bronchiectasis can occur in these settings as well. So, what is the pathophysiology of bronchiectasis? There is epithelial injury and there is mucus hypersecretion because of mucus secretagogues, celiotoxin, reactive oxygen species, proteinase enzyme. These are all the consequences of infection leading to epithelial injury, mucus hypersecretion. This epithelial injury and mucus hypersecretion will lead to reduced mucociliary clearance and there is plugging of airway due to mucus plug, and that leads to chronic bronchial infection. Also, this epithelial injury and mucus hypersecretion can itself lead to chronic bronchial infection and it can again lead to same. So, vice versa it can be. And this mucus secretagogue, celiotoxin, reactive oxygen species and the proteinases can, we know that they all lead to inflammation, and this inflammation because of the chemical mediated interleukin 8, tumor necrosis factor alpha and the leukotriene B4 again are important in producing chronic bronchial infection, and chronic bronchial infection itself can produce inflammation. So, however be and whatever be the relationship, the reduced mucociliary clearance and plugging of airway along with inflammation and chronic bronchial infection together will lead to airway damage and producing what is called a permanent dilatation of the bronchi, and this inflammation again leads to reactive oxygen species and increased elastase from the neutrophils due to inflammatory cell influx, and also matrix metalloproteinases from the epithelial cell. All these things further aggravate the airway damage and resulting in bronchiectasis. Coming to the morphology or pathology of bronchiectasis, grossly there are three types. One is called the cylindrical bronchiectasis. Here we have, this is the normal bronchi, and this is cylindrical where there is uniform permanent dilatation of the bronchi leading to cylindrical type, and there is what is called a varicose type, which is kind of spiraling and which is kind of undulating, and there is saccular or cystic, which is seen in very typically seen in cystic fibrosis. That is why the name cystic fibrosis has come. Coming to the microscopy, what do we see under the microscope? We see that the airways are dilated So, these dilated airways, you can see there is a dilatation of the bronchus with ulceration, acute and chronic inflammatory cell infiltrate in the bronchial wall. And the lining epithelium undergoes ulceration or what is called discontinuity and desquamation. There can also be squamous metaplasia because of the chronic irritant and pseudostratification, and finally necrosis of lung tissue with abscess formation and fibrosis. And when you look at the lung grossly, you have what is called this typical honeycomb appearance, where you see multiple dilated bronchi leading to something like a honeycomb appearance. So, in summary, coming to the pathogenesis of chronic obstructive pulmonary diseases, that is COPD, chronic obstructive pulmonary disease is a preventable common condition with a high morbidity and mortality, characterized by progressive permanent airflow limitation that is not fully reversible. So, this is what is very important. There is a progressive permanent airflow limitation which is not fully reversible, and substantial overlap and coexistence of the types, that is the emphysema, chronic bronchitis and bronchial asthma may occur in many patients. So, we will have to be careful which stage and what disease is prominent and what disease is predominant, and likewise treat the patient accordingly. Then injury from smoking, most important factor in development of chronic obstructive pulmonary diseases, excites inflammation which leads to cellular and extracellular matrix injury, which heals with incomplete and disorganized repair mechanisms, finally leading to permanent progressive airflow obstruction, leading to either bronchitis or emphysema, and also may be a trigger in bronchial asthma. The airflow limitation is associated with an abnormal inflammatory response on exposure to noxious particles or gases, particularly cigarette smoking. Again, the emphasis on smoking. And other important emphasis on deficiency of antiprotease activity makes individuals particularly susceptible to the pathologic process with earlier and more severe disease presentation, that is emphysema. Patients with COPD present late with chronic respiratory symptoms, and majority of the early stage is asymptomatic, and that is why it becomes very important to diagnose at an earlier stage and hence needs a high index of suspicion for diagnosis. And pulmonary function tests reveal airflow obstruction, that is a forced expiratory volume in 1 second FEV1 bar the forced vital capacity FVC. If the ratio is less than 0.7, it is considered to be a diagnostic or a suspicious marker for what is called chronic obstructive pulmonary disease, which is incompletely reversible. So, with this I finish the entire pathogenesis of chronic obstructive lung diseases, including chronic obstructive pulmonary diseases. Thank you.